Hello and welcome to the show. Today we have a very special guest, Carol Petersen. Carol is an accomplished compounding pharmacist with over 30 years of experience helping patients improve their quality of life through bioidentical hormone replacement therapy. Carol graduated from the University of Wisconsin School of Pharmacy and is a certified nutritional practitioner. Her passion to optimize health and commitment to compounding is evident in her involvement with organizations such as the International College of Integrated Medicine, the American College of Apothecaries, American Pharmacists Association, and the Alliance for Pharmacy Compounding. She was also the founder and first chair for the Compounding Special Interest Group with the American Pharmacists Association. She is chair for the Integrated Medicine Consortium, co-hosts a radio show called Take Charge of Your Health, and is on the medical advisory board for the Center for Menstrual Cycle and Ovulation Research. Wow, that's quite a list of accomplishments. Welcome to the show, Carol.
Yeah, I've been busy in this hormone space. So way back 30 years ago, I started working with Women's International Pharmacy and treating severe PMS.
Mm-hmm.
So the good thing about this experience, it made me understand how you can treat severe PMS and the same symptoms trickle over into perimenopause, menopause. They are symptoms of hormone deficiencies.
Mm-hmm.
And I learned at that time from the groundworking work of Dr. Katerina Dalton that PMS can be treated very effectively with progesterone. It doesn't matter if the symptoms are emotional or physical, like the breast tenderness, the aches and pains, water retention. So the whole gamut of what progesterone does in the body, I think, is still not very much understood and appreciated. And that's one of the problems. So I saw great success with dosing some pretty high doses of progesterone to relieve these symptoms. And if there was breakthrough, you had to use more. It was everybody in this space was really understanding that. And then we sort of had a good impact and a alarming impact, and that was from Dr. John Lee, who wrote a very good book on progesterone, Multiple Roles of a Remarkable Hormone. It's an excellent book. But he stated that our body only makes 20 milligrams of progesterone per day, and that's all you need. And he promoted a product called Progest at the time, had about 16 milligrams of progesterone. And he said that would work just fine, just one a day dose of that. Well, at the time, Dr. Julian Whitaker had a newsletter, and he touched on the topic of bioidentical hormones. And he referred to our pharmacy to get hormone by prescription with compounding, but he also said you could buy Progest there. Well, we didn't even have Progest, so we quickly got it. Mm-hmm. But then all these women who were studying on Progest a little bit, they were having a terrible time. Mm. And so they call us back and say, I'm having this and this and this. Of course, we're already trained to treat these symptoms with higher doses. So we counsel them to check with their practitioners and use much more generous dosing. I heard John Lee in a lecture at one point say, he must have been getting some criticisms too, because he said women are complaining about these symptoms. And he said, just do it, keep doing it every day. In 9 months, you'll be fine. So who's going to put up with that? Not me, for sure.
9 months. Thanks.
Not me. So yeah. I know from those breakthrough symptoms of the PMSers, you can get rid of that in an hour or two. Mm-hmm. Why would you slowly and steadily do that for a long period of time before you expect results? There's another negative here with the lower doses. progesterone can provoke enhanced estrogen activity. So if you use a low dose, estrogen's immediately increased in its potency, but then you have diversion of progesterone to all the other things progesterone's doing in your body and not enough. So you are getting things like migraines and breast tenderness and fluid retention, more anxiety, all kinds of things. And if you leave yourself in that situation, I think this is very detrimental to your body to stay in that position. So I'm really opposed to, I just talked to a client today. She said, I started using 100 milligrams of progesterone. She said some things have gotten better, but there were other things that she still had trouble with, hot flashes. Her sleep quality wasn't as good. And she gets these palpitations once in a while. And progesterone should be taking care of all of that. But her doctor had given her a 100 milligram capsule, said, see me again in 3 months. So what's the person to do? You're putting her in a situation for 3 months she's supposed to suffer until at last she can talk to you.
Yeah.
And maybe you'd bump up the dose for her. That's unconscionable. And that's how our medical system is set up, really, to have get started on something, but you don't really evaluate for 3 months, 6
Right.
months. It should be done right away.
I always say that to clients, when you go on HRT, hopefully with a hormone literate provider, which is a challenge to find in and of itself, it's not like a set it and forget it. You need to be in constant communication with them to let them know how you're feeling, what's changed, what is worse, what has improved, so that they can make tweaks to that regimen. Okay, so since we started talking about dosing, let's just like keep with this conversation, because I'm a health coach. I don't prescribe, but I have my own history of a lot of health issues, and starting perimenopause in my late 30s, the symptoms, they were screaming. And I knew, because of my history learning about hormones, the work that I do supporting women, I'm like, oh my gosh, it's starting. But what I have learned from mentors and just the education is you go low and slow with hormones. And perhaps that's true with testosterone or even estrogen, but you don't believe that to be true for progesterone. So you just spoke about that a little bit. Can you talk a little bit more? And even in regards to what you just said about how it affects estrogen, because I do hear that with women. And when I talk to them, they're typically on a low dose of progesterone and they're experiencing a lot of these estrogen-like or estrogen dominant-like symptoms.
Right. And unless you've pre-warned them, they think it's side effects of progesterone. And you mentioned, as we talked earlier, about progesterone sensitivity. You provoke that with the low dose. It's not that the patient is sensitive. The low dose by the prescriber or coach provoked it. It's predictable, 100% predictable. These things are going to happen. So before you conclude that progesterone is not for you, I did write a blog about when women don't like progesterone. I had two women email me to criticize me. They said, I shouldn't say don't like, hate is a better word.
Yeah.
But there are reasons for it. And I put in as many as I could think about, and probably there's more. But pre-warning anybody before they start progesterone, or we have a lot of progesterone creams over the counter. And some of that, you can go to some of the health food stores and get a low dose cream and try it. And then it doesn't go well because you don't have the knowledge base. And then you become convinced this is not for you. And so that's it. It's a terrible barrier to somebody who really needs a lot of progesterone to even restart and give it another chance. So a huge educational piece has got to be there, both for practitioners and their patients. It's just not happening.
So what is like and I don't know if you could answer this, like a typical dose that women would benefit from, and how do you know who will react a certain way? Like, I mean, I've heard some people say, oh, you can start a woman as low as 25 milligrams, but others need 200. So how do you even know?
Okay, well, look at the history. There you go in your intake. The
Mhm.
person tells you they may have years of birth control pill use in their background. Maybe they've had a hysterectomy. I would submit to you that almost all reasons for a hysterectomy are tied into low progesterone.
Mhm.
And then insult on injury, if you have taken your organs out, your prescriber gives you estrogen. You already had too much estrogen relative to progesterone. So here you go off into the future with only anti-anxiety drugs, sleep aids, antidepressants, blood pressure medication, maybe even heart medication, induced by that excess estrogen deliberately prescribed to you. There's a pathway about your bone health. And that's what they say. Oh, you have to have estrogen for your bones. At best, progesterone slows down the rate of bone loss. It's progesterone that rebuilds your bones. This is what you need. You need to be in the rebuilding, constant rebuilding to have healthy bones. So there's a pathway through prolactin. With estrogen only, prolactin increases. And then when it's high, it provokes parathyroid hormone to pull calcium out of your bones. So your osteoporosis protection actually is increasing your osteoporosis.
Ugh. It's so infuriating because we have so much unlearning to do.
I know. It's we have a problem in our medical system. It's I wrote a blog on a tyranny of flowchart medicine.
Mhm.
If this and then that. And so practitioners are not trained to look at the whole big picture. They're
Correct.
they're, they're trained to look at one symptom. Oh, you have vasomotor symptoms, premerence for that, and end of discussion. Just
Right. Let's not look at the whole body and all the systems.
yeah, and that's extremely important. I think it's also underutilized. A lot of companies are offering hormone testing.
Mhm.
It's just a little piece of the hormone picture. You should look at every single thing produced from cholesterol. And that includes sex hormones, adrenal hormones, vitamin D, bile. How's that going? All of these things need to be taken into account. And then you need the other systems like insulin glucose and thyroid to
Mhm.
have a real thorough look at what's going on. One very alarming trend I'm seeing is this insulin glucose dysregulation. And we really do know very well that our population is becoming more and more insulin resistant. And this starts this provocative stuff with you go to sleep, wake up in the morning, in the night, you've got adrenaline surges because your blood glucose has gone down. You can't go back to sleep. And that indeed has another set of problems. If this is persistent at times, and it is, I know women like they're in this steady state of anxiety with no relief. They can't detoxify their hormones very well. So you have to look at the liver and you have to look at methylation. So it's really a multi-system thing you have to look at. And maybe even with the tests we have right now that are metabolic panels and things, maybe they still aren't enough. I don't know. It's still, I discover new things all the time.
Oh, yes.
I just,
It's never ending. Every
I
time I learn
know.
something, I'm like, whoa, mind blown. Even just finding your work, I was like, wow. So I just want to kind of go over some of the symptoms of progesterone deficiency because I'm going to link to this in the show notes, but you have a blog on your website that it's called Symptoms of Progesterone Deficiency. And I started reading it. There are 127 symptoms listed, and they're ranging from anxiety, PMS, fibroids, cystic breasts, night sweats, hair loss, to even feelings of resentment, uselessness, guilt, depression, panic attacks, irrational fears, agoraphobia. I was just like, the list goes on. And I said to myself, why is not every woman on progesterone?
And every man.
And every man, yes. I was listening to a recent one you did with one of my mentors, Jill, and you were talking about that, and I immediately was like, "Oh my gosh, I have to give my partner progesterone." Yeah, can you speak to all of that? What I just said.
Well, it's a tremendous amount of symptoms, and that becomes one of the problems. If you don't know what those deficiency symptoms look like, in our society, we tend to blame it as an estrogen deficiency, and people are being treated the wrong way. I even see, after I left Women's International Pharmacy, I went to Facebook because I was looking for interactions with people, which I certainly had a lot of. And what I was particularly looking for was the failures.
Mm.
And there's a lot of self-help groups put together on Facebook, and it's really very valid. Women have been seeking information and trying to improve their own health. They may have gone to 20, 30 doctors with no results. So to go there and see what people are complaining about. I was for a while there, I was doing Facebook to 2 o'clock in the morning, answering questions because it was so pervasive. And then somebody asked me if progesterone is the only hormone I know.
Well, it's a miracle hormone, so, and it's just so underutilized. So I see why you're so passionate about it.
I said no, but everybody here is so progesterone deficient. You've got to make that up first.
Mm-hmm.
So that's the thing. It's the first hormone to decline, although you probably can say this for DHEA too. It's declining right along. But when you get those first symptoms of perimenopause, it is almost all low progesterone.
Mm-hmm.
And for the most part, if women bring this to their practitioners, they're ignored because they haven't become menopausal yet. You can't test that. They're not making any hormones. One of the advantages, though, of having saliva hormone testing way back when, it sort of broke through an impediment because women would know instinctively that something was off with their hormones, and their doctors wouldn't listen. So they go off and get a saliva test and show, look, this and this and this and this are low.
Mm-hmm.
And then, strangely enough, practitioners would react more to the test results, than to what they've been hearing all along.
Mm-hmm.
And this gave women a foot in with their practitioners, saying, I arranged for this test for me, and look at this. And this is what I'm saying. These symptoms correspond with low hormones. I'd like your help. So it did serve a purpose. I will say, I don't like to use saliva testing for monitoring. Hormones go into exceptionally high levels if you use them topically rather than oral.
Mm-hmm.
So what's that supposed to mean? One person, one person, all these years, 30 years, no good answer. Except for one practitioner says, the only thing I can tell you about hormones in the saliva is that the hormones are in the saliva. Mm-hmm. And so saliva test companies have even gone so far as to have two ranges, normal ranges, and then a treated range. Where do you get that? Mm-hmm. They made it up. And when somebody is using these tests and they're using this for guidance, it's on a slippery slope. Mm-hmm. We don't have corresponding clinical studies to show, oh, this saliva test equals relief of all your symptoms. We just don't have that. And they had the problem with, okay, you had low hormones, and if you put it into the normal range and you did it with topical, your symptoms were not relieved. So they created a new higher one. I would say maybe that's not high enough. Maybe it needs to be right up there. But when you're making up stuff to evaluate, it's not a good place to be. So saliva has some merit in first diagnosing, but I don't see merit in using it as a test modality to follow unless you use oral hormones.
So you're saying once somebody starts hormone replacement therapy,
Yeah.
you wouldn't use saliva to monitor. Yeah.
Yeah.
Okay. Well, since we're on the topic, what about hormone testing in general? What are your thoughts on it? And do you feel like there's anything that's more reliable than another in regards to serum, saliva, urine? It's quite a business, hormone testing.
Yes, it is. And I would say 99% of your success in diagnosing and following somebody is clinical observations. And I worked for many years with this pharmacy, and we, each of us might have talked to 50, 60 women in a day, and we're able to make suggestions, go up on this, go down on this very, very easily, just from the results of what the patient is saying and knowing what each hormone does and is capable of doing, whether it's too low or too high. So one of the things that doesn't really sit well with conventional medicine, because they like if this and that too much, when you have to spend time with a patient and evaluate their clinical symptoms, where they are and what could be improved, they don't want to spend that kind of time. In this world, I almost always end the consultation with demand 100%. We are so much put off with trying to get healthcare for ourselves or some sort of advice, and we too often get the response, well, this is what you have to do, and if it's not quite right, you just have to put up with it for the rest of your life. And that's not acceptable. With hormones, you should demand that you have a hormone therapy that makes you comfortable 100%. If you're at 80%, it's not so bad. Not good enough. It's not good enough for your body.
I see women in their 50s and beyond that just have been ignored, dismissed, and it breaks my heart. Can you touch a little bit upon like the different types of progesterone therapy? Because there is a lot out there in regards to topical, oral, troches, all the things. And a lot of providers will say that oral trumps transdermal. And I know you have different schools of thought on that as well.
Okay, so people ask, what's my favorite dosage form? And I said, I don't really care what you use as long as you get progesterone in. And there's some advantages and disadvantages for each of the forms. Like oral tends to make more allopregnanolone, which can cause dizziness, drowsiness, sleepiness. Although way back when, we hardly saw this. It was years before it came to our consciousness that this was a big problem, which is interesting because we make a big deal about it. Take your oral progesterone at night because it's going to whack you out. Not necessarily true. We were dosing for PMS 100 milligrams of progesterone 4 times a day, and this came up really, really rarely. If it did, we'd say switch to another dosage form. If your gut is overrun with candida, I wouldn't do oral.
Okay.
It's only going to cause problems. Oral progesterone does change your progesterone level and serum tests, usually peaking about 6 hours after your last dose. So you can see a change. And this is, I'll touch on the controversy, like only oral progesterone protects your uterus because you've been able to get the progesterone into the higher luteal levels of the hormone. And then ipso facto, you're protected. Well, that's garbage. You don't know if they're protected unless you actually check if there's unusual bleeding. You need an ultrasound to really establish that you're not building up the endometrium. And you need an ultrasound, the same thing, no matter what dosage form. If there's unusual spotting or anything, off you should go to get that checked. And if it is the case, you're not using enough progesterone to either keep the endometrium quiet if you're postmenopausal and using some of both, or if you're treating perimenopausal symptoms, you haven't treated 2 weeks out of the month with progesterone and you're building up a layer. And then the second 2 weeks, you might not have enough progesterone for its full secretory effect to get rid of it all. So here's a controversy, but if you go to your conventional doctor now, and they've been trained by North American Menopause Society, the Endocrine Society, the American College of Obstetrics and Gynecology, they usually have a committee that decides this thing, and that's what all your practitioners are going to do, whether it works or not. Just so that's the controversy there. 24-hour urine tests have to be looked at a little bit differently. That's not in your body right now, it's excretion, but we make the assumption that's a reflection of what's been available to your body in the day you collected the urine. Very good. It's a gold standard. There's tons of literature, medical literature on 24-hour urine collection. I have some concerns about the spot urine because it is not supported by the medical literature, scientific literature. Maybe it will eventually do so, but right now, not. And I don't know, or is it revealed? You get one number, you do 5 collections, and they use an algorithm to give you one number. So how did they get there? Could you have had wild swings this way and that? I'd like to see all 5 numbers instead of the one number. But the important thing about it, and any test, never come to any conclusion about a test without the context of the person telling you what's going on. I get people randomly sending me tests. I said, what do you think I should do? I said, book some time with me because I'm not going to jump to any conclusions.
I say that to clients too. I'm like, sometimes they'll bring us tests that they did with other providers. And I'm like, what does this tell me? This is one point in time. And symptoms don't lie, because they'll often say, oh, well, they did this test and they said that my progesterone is fine. I'm like, okay, maybe when you took it, it was, but you're telling me you got all these symptoms of low progesterone. You're over the age of 35. It's not rocket science, but a lot of providers are still just treating based on test results, which is unfortunate. Getting back to the transdermal versus oral, and I wanted to ask this prior and I didn't, and maybe this can kind of bring us into another topic is mood disorders. And I thought you mentioned this, maybe it was elsewhere, about how when some women take oral progesterone, it affects their mood negatively. And is this the case for like a woman with PMDD?
If you're getting anything negative outside of the allopregnanolone, which actually can be a good thing, it's working at the GABA receptor to calm you down. It's much more potent than progesterone is, and so that's a positive. Recently, to my surprise, I just want to share this nugget. And I think I found it in this book, Fishy Business, which I recommend highly. And it said, if you had low cholesterol, the stimulation to the GABA receptors was diminished, or the receptivity to the GABA receptors was diminished. And at one point, I had 6 clients in a row with cholesterol levels almost incompatible with life, I thought. One was 86 and the highest was 132. This is crazy. Ideal cholesterol is like 210 to 280. And and these were untreated with statins. This is just their normal situation.
Wow.
But then we go ahead and we take normal cholesterol levels, and women are really being targeted without any evidence in the literature of any good at all for women. They're being pushed into taking a statin, and this diminishes 100% your ability to make hormones.
Yep.
It diminishes 100% for you to maintain your body integrity.
The fear around cholesterol is so infuriating. And I see it. I mean, with my own mom, we butt heads about it because she's in her 70s and she knows what I do for a living. And I'm like, why are you on a statin? Why? Let me see your lipids. Let me look at a full, and her doctor does like total cholesterol. And he's like, oh yeah, your cholesterol's high. And it's like, it's only in the 200s. I'm like, Mom, I mean, she's definitely opened her eyes a lot from what I have taught her, but she still has fear because he'll say to her like, oh, well, you're at risk of a stroke. And it's mind blowing to me that they just say these things to women and create so much fear. And meanwhile, my mom has a lot of symptoms because she's postmenopausal and nobody ever offered her hormone replacement therapy. But let's just keep lowering her cholesterol, the thing that helps you produce hormones in the body. It's so difficult not to get angry.
I know. I had a business associate, also a pharmacist, and she took statins for many years. And she developed this nervous system dysfunction. Her husband took her place after place after place. I gave her Broda Barnes' book about hypothyroidism, the unsuspected illness, and got her to read it. She was clearly hypothyroid. You just have to look at somebody and you can tell. And yet, it didn't blow her away like it blew me away. And I said, you got to pay attention to your thyroid, not the statins. So she proceeded to use statins until she died. She died at 68, and she was pretty much incapacitated, and she shook all over and whatnot. On autopsy, they said she'd developed ALS. About a year later, I found a paper popped into my universe, and it said statin drugs cause ALS. So,
and we have such a weird relationship, I guess, or viewpoint of doctors. People look to them as authority and take their word as gospel. And I don't understand it. I really don't. I mean, when I was in my 20s, I questioned doctors because I felt horrible. And I kept thinking, this can't be normal. I'm in my 20s. Why do I feel so lousy? Like, what's the rest of my life going to be like? So I wasn't married, so to speak, to any doctor because I thought, well, if you're not helping me, I'm going to find somebody else who will. They're a dime a dozen. There's good doctors and there's bad doctors, just like any other profession. So I find it so infuriating when women will continue to go to the same doctor over and over and not get any satisfaction. I'm like, you do realize there are other people who could support you, right? Anyway, part of what I do is not only educate, but I really try to motivate women and kind of give them a little fire under their butt. Like, this is your life. You only get one chance here. So do you want to feel good or do you want to continue to struggle? Just to be nice and respectful to the doctor that you've been going to. Find someone else who's going to help you. So
here's the nice thing about progesterone, because I think it helps women break through. Once you have somebody who trusts in using bigger doses, and they actually are completely transformed, things that they've been suffering with for ages just melt right off. And suddenly they have the realization that now they have progesterone available and can use it. They have the means to take charge of their own body and control what's happening to it. They're no longer the victim of a panic attack. They know what to do with it. They're no longer a victim of breast tenderness. They know what to do with it. And all of a sudden, women who are doing this, they're empowered to take care of themselves like they never were before. And it can be life-changing. So I delight in that.
Yeah.
And this woman,
Hormones are life. I say that often. I'm like, team hormones. Yeah.
a woman I talked to about a week ago, she said, I'd been listening to some of your information before my appointment. She said, my doctor gave me 200 milligrams of progesterone. She said, I took 400. And she said, the difference was phenomenal. But she said, I think I'm an 800 woman.
Wow. That's
So,
high. I mean, to me, that's high. I started on 100 milligrams because that's what I was told to do. And that's what I learned. Like, oh, you start low and slow, like we talked about earlier. And now I'm at 150 and I'm like, I think I'm still too low. I mean, I feel pretty good, but I'm going to book it with you anyway, because I want to talk about my case. I won't use up this time for that, but I feel like even 150 is very low.
yeah, it is.
Yeah.
And back when we were doing the severe PMSers, the starting dose, as I said before, was 100 milligrams, oral capsules 4 times a day. But we went up from there, and then pretty soon we're compounding every which way, creams and gels, vaginal suppository, rectal solutions, lozenges, drops, anything to get the progesterone up, and it would then work. The symptoms would be resolved. At the time, one time I counted the number of milligrams one particular woman was using, and she was on very generous dose. All total 2,500 milligrams a day in the luteal phase. So I've seen higher now. Sometimes when women are having to use the over-the-counter creams, and they need more and more and more. I've seen higher doses. What can happen with the creams is that the progesterone is suspended in the cream. It's partially dissolved in the oils in the cream, but the rest of it is just sitting there in a powder form. And when you put it on your skin oils need to complete the solution. It's not going to go through your skin barrier until that happens. And so you could have somebody say, I get white powder on my skin when I use the cream, so that they haven't absorbed all of that. You can recommend they grab some oil, coconut oil or a lotion or something, just to add more oils to complete the solution of it. The problem with creams is that in a hypothyroid person, you're going to have less skin oils, and you're going to have a decreased circulation to the skin, which makes it much harder to get in. Or as we age, same thing happens. Our skin does not absorb the progesterone out of a cream as well as it could. Hence the other opportunities. Vaginal application is good. Rectal application is good. There's somebody compounding progesterone in a nasal spray now.
Wow. Okay.
Yeah, all good.
Great. Yeah, great. Sign me up. That's very interesting about the skin and not absorbing properly. I was going to ask about that as well, because it doesn't even occur to you, like some women have really dry skin, and it's like, well, why do you have dry skin? Thyroid's not functioning optimally, estrogen is low. So okay, that's good to know. Yeah, because a lot of women, unfortunately, not unfortunately, maybe you can say fortunately and unfortunately, they have to DIY their own progesterone because they don't have access to a physician, a provider who will prescribe it. And that is so infuriating. So a lot of them are just like going online, going on Amazon or whatever, looking for progesterone cream. So then they're experimenting themselves just to find some relief. But it's unfortunate that they're not getting the support they need, because if they are using it and they're not finding much relief, it could very well be that they're not absorbing properly. And that's not being addressed.
Right, it's a problem. At one site, they started recommending freezing your progesterone cream, like in a gummy mold, but you don't really even need that. You just need your little dose and freeze it. And that hardens it so you can use it vaginally.
Okay.
And you could have some improved absorption.
Mhm.
So I just marvel at the creativity of people. I just
You do what you have to do to feel
right.
good. I
Right.
get it. I get it. Women are really struggling, and I just said this morning on Instagram. By the time women even find me, or I'm sure people like you, like they are desperate for solutions, and then they find people that are just like, oh my gosh, like I'm not crazy. They feel so validated because for years they've been going to their standard medical doctor and being told, no, it's not possible. It's not your hormones. You're too young. Blah blah blah. I mean, you start to feel like you're losing your mind. It's like, I know I'm not imagining these symptoms. Um, so another topic I think is controversial, though I don't know why. I think it has to do with just everybody believes what they believe, or they've learned a certain way and they don't want to be open-minded, is the idea of cycling progesterone versus taking it continuously. I personally take it daily. I have experimented cycling it. I was like, what is the point of this? I felt lousy when I wasn't taking it. So right now I take it continuously, but I'd love to hear your take on this.
Okay. So there's a question, and we'll talk postmenopausally. Do you want to recreate that cycling? And so that was the basis of a book by Susan Wiley and Julie Taguchi. So one of the things it's very generous with hormones, which I have no objection to. I think probably we underuse even the other hormones as well.
Mhm.
And for 2 weeks, you would use estradiol only in increasing doses, and then in the second part of the cycle, you would add some larger doses of progesterone. However, I'm running across people who have used this, and they are building up too much tissue in the endometrium and having trouble shedding it. The amount, even though high, isn't allowing you to get rid of it. And then with no progesterone in the first part of the cycle, you're building up this excess endometrium. So the progesterone that happens in the first part of the cycle that we can measure in the serum is coming from the adrenal glands.
Mm.
And if you're 25, you might not have enough progesterone there in those days. So you need to have some so you don't build up these huge layers. And this is the problem with excessive bleeding that's so common. It's the most cause of going to hysterectomy of any other thing. And we do like 600,000 hysterectomies in the US. So consider that it's preventable with progesterone in the follicular phase, so you don't build up so much tissue. And you can correct this in a couple months. But we let women go till they're anemic and can hardly stand it because they can't go anywhere. They're bleeding so profusely, and even all the way to blood transfusions. Then when the doctor says, we'll just take everything off, you're ready. And so easy to fix. It's just terrific. And now it's gotten very popular to insert a Mirena coil, which has a progestin, and supposedly this is going to control your bleeding, although it may or may not. But what it will do is certainly muck up your endocrine system for sure. And I can't coach somebody with a Mirena coil, and they have to have it out because progesterone is being blocked by that foreign progestin. They're not going to go anyplace. You could try and pile on the progesterone. You're not going to get much result.
Yeah, because it's basically, what is it, blocking the receptors
Yeah,
because that dose is
for
so
sure.
high, the progestin.
Well, it doesn't matter what the dose is in that,
Doesn't matter.
and when they tell you it's a low dose, it's still very potent, even at a low dose. These drugs somehow have much more potency than the bioidentical hormones we're working with. It's hard to compare. You have to pick an activity and compare at that activity.
Yeah, that's what I'm seeing too, especially if a woman is sensitive to progesterone or they're having a reaction. Many providers will then say, well, you can take an IUD instead. And we have had some clients, I always tell them, I don't judge you for your choices, but This is what you should know. Maybe I am a little judgy. This is what you should know. You're not going to get the same benefits as you would from bioidentical progesterone, as you would, from whatever they're telling you the progestin is going to do.
Yeah. And this is another problem because they're told it has progesterone in it.
Oh yeah, they're used interchangeably, those terms.
Yes. And you have to be so careful. So even in the literature, medical and scientific literature, they often intermingle those terms, so you don't know what's happening. There's a study out, I don't know, 6 million women, and they actually had a part where they were reporting on women using progesterone. And so they were implying that there was increased cancer in the progesterone users. However, quite possible if you're using too little progesterone. I wrote the author, who is not, responded to me. And I said, I'd really like your raw data on what doses of progesterone that you reported on in this study, because we know that progesterone is biphasic, right? that at certain doses, it will do exactly the opposite of what you want. So if these women are underdosed for their in this particular study, this is the kind of result you're going to get. So what does it translate into the community? You're making a statement and not providing the background to it. And the statement is going to prevail and scare women away from using progesterone, when it's the very thing that would help them. This is done time and time again. So it's very sad. Actually, California, the state of California, puts a cancer warning on progesterone over the counter. It's Prop 60 or something like that. So I had, she was a patient, and her daughter, she and her daughter had done very well with progesterone, and she wanted to get that off. And so she was getting politically active. So at the time, I got all 80 studies that they based that decision on. Guess what? Not a single one were on progesterone. Zero. So they made that decision to put a cancer warning on it for progestins, and it's entirely untrue with progesterone. Yeah. And they refused to reconsider, because we were ready to provide other information that they could reconsider their position on progesterone. This is how this ignorance gets into the newspapers. It gets into practitioners' minds. They're actually taught at some of these organizations, all estrogens are alike, all progesterone and progestins are alike. This is how they're taught. Sometimes women bring that to me, that their doctor says that. And I say, oh, did your doctor pass his physiology course?
Oh my gosh, you're fresh. I love it. Yeah. I mean, again, so many people, women, look to their doctors for answers, that they think that they're the experts. And I say over and over, not when it comes to women's hormones, or a lot of things, but especially women's hormones.
There was a New York Times magazine article. It's probably been about a year now. Susan Diadama is she's a very celebrated writer, and she's a good writer. So she was experiencing menopausal symptoms, and she goes out to do research on this. She and her colleagues, they're grasping for words, can't remember stuff, things like that. And so she goes to the big NYU, Columbia, Mount Sinai, whatever there is, all the teaching hospitals. And she gets very little help. She's recommended some of the hormone therapies. In the end, she picked birth control pills, which is also being marketed heavily to menopausal women. That's what she decided to do. The irony of all this is that I know there are tons of doctors in the New York City area that do bioidentical hormones, and could help her very well. and she never even interviewed one. I
Oh, wow.
just, and then I got one other nugget from that in these teaching hospitals. So the young trainees are taught there's nothing you can do about it. So they're not even teaching anything about menopause anymore.
It's just mind blowing. This day and age, we have so much research, we have so much data, and the curriculum still has not changed. And now it sounds like it's gotten even worse.
It's gotten worse. It's shocking.
What are your thoughts on FDA approved Prometrium or commercial Prometrium versus compounded progesterone?
Okay, actually, when we were compounding those 100 milligram capsules, we started in safflower oil. The original studies were with that, but we switched to olive oil because we didn't want the PUFA.
Mhm.
And that did very well. We actually, Women's International Pharmacy had a patent on this. It's a use patent to put it in a vegetable oil. So ultimately, the company that makes Prometrium copied that, and they used peanut oil for some obscure reason. Maybe that wasn't in the earlier patent or something. So that actually came later. And so we're stuck with a product that does contain some dyes and the peanut oil. So I would say it's inferior to some of the compounded ones. Having the oil with progesterone does help absorption, which is a plus. But if you have to avoid peanut oil, you've got to avoid that.
I want to speak a little bit more about like the headaches that women are getting, the anxiety. I've even heard some women at higher doses of progesterone have had some reactions in regards to mood disorders. Can you speak a little bit more to that? Like in terms of troubleshooting, why do you think that's happening, even at like a higher dose?
The dose may not be high enough still,
Still.
and where that's going to be. You have this intense amount of estrogen. Estrogen could be high, makes it worse, and adrenaline, and that's dependent on the insulin glucose dysregulation and methylation happening or not happening. So it can be a little bit of a complicated thing, and you need to use quite a lot to get there. My personal position is let's use progesterone liberally till you reach a point of comfort.
Mhm.
Then let's look at what contributed to your excessive need for the progesterone to reach comfort. Whether it's insulin glucose you've got to regulate, whether it's you have allergy reactions, you have a disordered gut microbiome, you're loaded with xenoestrogens, you need to detox, your liver's not working well. There's a lot of things to address. When we first started, it occurred to me that we were using these very large doses of progesterone to get to comfort. But so I said, what about the other side, where that burden is so big? So then I thought, aren't there things we can do to decrease that burden? Then you don't need as much progesterone. And I believe that's so. So from that point of comfort, then you can start reasonably and rationally going after the other stuff. Maybe it's the mercury amalgam in your teeth you better get out.
Mhm.
There's so many things, and that's where somebody who can coach men and women with all of these diverse things that can contribute to feeling not well and not balanced with your hormones. I think for the most part, there's a lot of coaching needed to handle this and look for directions.
Yeah.
But
Yeah,
it's
because
much easier to do when somebody's reached the calm than when they're freaking out and hugely anxious and can hardly think. This is another problem with high adrenaline. I'm asking them to change their diet to one that isn't whipping around insulin glucose so much. They don't want to eat at all. The adrenaline doesn't makes them not hungry.
I would say that about 90% of the women that come to work with us are under eating. They have a very low appetite, especially in the morning. So we focus a lot on nervous system support. But I often say to clients when they're coming to us, and I could tell right off the bat, they are high anxiety, overwhelm. I I don't want to add one more thing to their plate. And by me saying, oh, you need to be eating this, this, and this every day, and you need to be working out and you need to be walking, they're not going to do it if their hormones are so out of whack. And I say, some women, you need to go on HRT so that you could do all these food and lifestyle changes. You're not going to have motivation or the drive to do anything if you feel like you're going crazy, quite frankly, or you're so fatigued because you're not sleeping well. You're so anxious because you have so much going on, and just women in general nowadays have so much on their plate. We're living in some very stressful times. I mean, I feel like historically there's always been some sort of stress, but it just feels really loud right now.
It's not your grandmother's menopause anymore.
No, it's not.
I do.
I do believe, and you mentioned, I think endocrine disruptors or just the xenoestrogens in our environment. Do you want to speak to that a little bit?
Oh, and how about glyphosate, which is pervasive in the US? And there are labs you can use to check your glyphosate levels.
Yeah, the
And
pesticide glyphosate.
yeah, I did it for myself, and I was horrified because it was moderately high. And I choose to eat organic as much as I can, you know, I'm careful. I go, whoa, this has got really big impact here. What do you do with glyphosate? You got to detox it. You gotta make sure your liver works well. You've got to sweat, do saunas and things to get it out of you.
We could change our diet. We can change the products that we're using, but the toxins that we're surrounded with in our environment, it's kind of out of our control.
Yeah, and it's so overwhelming. The best thing you can do is take care of yourself as well as you can.
Yeah.
And be as informed as you can. I've been recommending COCA pulse test. Are you familiar with it?
What is it?
The COCA pulse test.
I've never heard of that.
So there's a nice little book about it. And if you're eating and your resting pulse rate goes up by 10 beats per minute or more, you have a food sensitivity to what you just ate. So you know, you can start monitoring yourself and pulling away the offending food from your diet. That increased pulse rate is increased adrenaline, more work for your progesterone to try to balance. So it can be, I talked to one client, she goes, oh, that happens to me all the time. She said, I'm even afraid to eat sometimes because my heart starts beating so hard. I said, pay attention to what you just ate. I said, it's really good that you already have an awareness. I said, now do something about it. You need to stop that food for at least 3 months before you try introducing it again. And this in turn is whipping around your insulin glucose and continuing a problem. I'd like to give people things they can monitor, like for your thyroid. Make sure when you take your temperature, you're somewhere around 98. And Ray Pease says your pulse rate should be in the 80s. So I've talked to people, their pulse rate is 60s and it's been so their whole life, but we're not paying attention.
No.
And thyroid's a big player too. And we already have a bad history of treating low thyroid people. We rely on tests again, sometimes only one test, and a few doctors like to order a whole thyroid panel, but even so, you need context with everything else with that. And so many people are low thyroid, and their metabolic rate is compromised. So I say, you know, your thyroid, T3, active thyroid hormone, helps you your mitochondria work. The other thing that increases your metabolic activity is exercise. But if you're a low thyroid person, you only should do slow, sustained exercise, and you actually will feel good because you warm up your body temperature rises, your metabolic rate rises, and you feel good. If you can't have a thyroid hormone just then, that's your alternative to get in movement, get in a long walk, go swimming. Anything that can increase your metabolic rate makes you feel better.
Yeah. Yeah, it seems like a lot of women are overdoing exercise, and aren't paying attention. They don't even think that they have a thyroid problem. And then, there's so much out there right now in regards to diet and fasting. And we see a lot of women who undereat or who fast for really long, and they don't realize how that can impact their thyroid, negatively. I mean, there's benefits certainly to fasting, but I just have always seen women doing it incorrectly and end up just in a major calorie deficit. And then they're not getting the results that they want, and they don't understand why. So we almost have to have them reverse diet and make them eat more and slow down. It's like the complete opposite of what they've been told to do, and they think
Yeah,
we're crazy at first. And I'm like, just bear with me.
yeah, yeah.
Yeah,
That's good advice.
yeah.
So right, one of the things that hard exercise does is increase cortisol, and
Mhm.
that has a depressant effect on your testosterone and thyroid, and so you actually get a negative result. And fasting for some can be a highly stressful situation. You can have the same rise in cortisol that produces a negative effect from the stress of the fasting. So you're quite right. It's not for everybody.
Yeah, and the other thing, I think you may have mentioned this earlier, but how does stress affect progesterone levels? And if somebody is really stressed and then they take progesterone, doesn't progesterone kind of have a hard time doing its job when the cortisol is constantly high?
Right. One metabolic step between progesterone and hydrocortisone. So progesterone is also an adrenal hormone, as I mentioned. It's highly involved with adrenal activity. One step, and you make more cortisol, and then you make cortisone and all the other derivatives. All that can be really down when you've had like an extremely acute stress, could be draining the whole kit and caboodle, or you have chronic stress, but slow but sure, all your reserves are just gone. Progesterone, for the most part, converts and helps you fill in that deficit. Talk about some people talk about storing hormones in your tissue, like you have little pools of some hormone or another. Yes, that's true if you're using pellets,
Hmm.
but your body doesn't do that. It's not getting stored, it's in and out. It starts its activity, starts an activity and then goes. One of the criticisms of bioidentical hormones is that they're short acting. They don't linger, they don't store. You can't rely on the dose you took yesterday to be helping you today. So that's a problem. People have been saying, oh, there's fat storage of hormones when you when you use hormone creams or whatever. I have yet to see the biopsy to show that. And I had a professor at pharmacy school who actually was a researcher with skin and eyes and stuff, and he eventually developed the product Crenone, and it was he had developed Replens, which was a vaginal lubricant. It was designed to adhere to the vaginal walls longer. So then they added progesterone with the same idea, that it would stay there longer without falling out, so you could get more progesterone activity from it. It's a pretty good idea, I think. So we asked him about fat storage since he knew skin and he knew progesterone. He goes, what a bunch of rubbish. And I tell you, I know a pharmacist who wrote a book, and it's used like a textbook in some of the training sessions of a certain group. And he's got that in there, fat storage. And he gave me his book, and I said, you said this. I said, what's your reference? Oh, he says, well, it seems like it should be true. I just like, no.
Oh, wow.
and and that's how these things, it gets taught like it's a truth, and nobody went down the rabbit hole to see where this came from. John Lee was fond of saying that. So I think, although he did raise awareness of progesterone, his low dose of progesterone, reliance on saliva testing and
Mm.
fat storage of hormones. So you got to rotate your spots. No, you don't. This is
Okay, that's good to know. I learned that as well, that you and a lot of people say that the hormone receptors need a break.
yeah, yeah. And why would that be? Does your body suddenly stop any hormone that it makes for
Right.
a day or two?
Yeah,
And
or
the
not
only
know what to
thing,
do with the hormones that your body makes.
yeah, yeah, the only thing you get is you get a return of symptoms.
Mm-hmm.
So hello, we don't say take your insulin 5 days a week.
Mm,
Just
right. Yeah.
it's craziness. But I think where this idea came from was Premarin.
Mm,
Because way back when Permarin was in a lot of use, those hormones accumulate big time. And I have a paper that identifies 60 different steroidal compounds in Premarin, and very few of those identical to the human. So your liver's going to have trouble metabolizing that. So it's going to be circulating around probably a long time. We don't even know how long.
wow.
So your increased burden of these hormones, stacks up when you can't get rid of them so easily. So they would say stuff like take Premarin 5 days out of 7,
Mm-hmm.
take a week off a month, whatever. So it's very popular. And I think some of this philosophy is driving this thing like give your body a break.
Mm-hmm.
But the bioidentical hormones, like I said, in and out of your body quickly. There's no reason for a break.
Okay. Yeah, I'm with you on that.
Yeah.
I joke around. I say I will hold on to these hormones, my HRT, until somebody pries it out of my hands.
Right.
I'm gonna be
Yeah.
buried with my hormones. I mean, like I said to you, when I started and I'm still young, I'm 41, but I started perimenopause earlier, and I do believe it has to do with my history. I was on hormonal birth control for about 13 years. I have a prolactinoma, which I do believe was in part due to being on hormonal birth control. And my estrogen was very low. I had low estrogen symptoms and obvious low progesterone symptoms. So I was dabbling with over the counter stuff for a while. I was taking every supplement you could imagine. And I wasn't finding relief in some very big symptoms. And I said, that's it. I'm going on HRT. And it changed my life, honestly. I even contemplated shutting down my business. I couldn't get words out. I had a hard time focusing. My anxiety was high. I wasn't sleeping. And then, of course, there's also, I was gaining weight. I wasn't able to lose it, more of the physical things. But um, I just refused. And I even had joint pain and my mood was low. I mean, the gamut
Yeah.
of symptoms. Um, it gets me like, I get very passionate, but also a little emotional about it because it makes me so sad that so many women are denied these hormones that are so life-giving that our body is meant to produce. And because of all of the environmental toxins, the amount of stress, the synthetic hormones, the medications, we see it younger and younger in women. I mean, we have some women in their early 30s who are struggling big time with their health and these hormone imbalances.
Well, let's talk a minute about COVID and the
Mm.
COVID vaccine. There's
Mhm.
evidence published that progesterone is tanked for these women and men, and the article suggested using progesterone therapeutically and also a corresponding one with cortisol
Mhm.
also tanks, which is not surprising, and that should be incorporated in the treatment where people have the so-called long COVID, like they never recover from whatever it is hit them, and
Mhm.
then damage from the vaccines really impair the hormones. We've got all kinds of endocrine problems cropping up, and we have huge amounts of miscarriages. If you happen to
Yep.
do it during pregnant, it's an atrocity, and it's still going on that we're having people push this on it, and has a terrible endocrine impact. It's not talked about as much So we're talking.
No, because if you bring it up, you're immediately called, an anti-vaxxer. It's like, well, why can't we have these educated, respectful conversations to look at side effects of anything that you're putting in your body, whether it's a vaccine, a medication, it doesn't matter. We need to be having this conversation, especially that people were unfortunately forced to have it. And I mean, I was very vocal about it during that time. I kept saying, like, wait a minute, we need to understand the impact of these long term. And what is this going to do? And we have seen a lot of health issues come from that. And, clients do say to us, oh, I was forced to get it, or they wanted to, or their doctor told them to get it. And again, it goes back to a lot of people just respect their doctors and they do what they're told and they ignore their own intuition. And I know even when it came out, the vaccines, I had questions about it. And when you talk about it, people, because there was so much fear around it, you get attacked for questioning things. And I always say fear is so debilitating and it makes you act irrationally.
Well, sometimes they say, like a miasm, it permeates everything. The fear permeates everything. And if you just count that one thing, the fear, you're gonna blow through all your cortisol derivatives. You're gonna suck out of your progesterone. It's relentless. There's fear prevailing all over our media, and the doctors buy into it.
Yeah.
Yeah, actually, it's a big thing. Actually, doctors are trained to make you afraid of something.
It feels that way. Thank you, Carol. I could talk to you for hours, but I want to be mindful of your time. Thank you so much for being here and for everything we covered. Maybe we'll have you back another time to talk about more progesterone and just other hormones in general.
Okay.
How can women work with you?
I have a website, the wellnessbydesignproject.com. I offer some consultations there. And I also offer tons of videos and blogs and things I've written. You should go ahead and browse. Everything's there in reference, and a good way to start your education. So I've had a couple clients say I've been watching you on YouTube. So I have a YouTube channel by the same name.
Okay, great.
Lots of these podcasts are there.
Awesome. Thank you. And we're going to link to all that in the show notes. I love your blog. I binge your blog posts and I've been sharing them with clients because they hear me. I'm going on and I preach and I'm like, here, look at this progesterone. I call you the progesterone queen. I have named you that. And I'm telling everyone like, oh, I'm having the progesterone queen on the podcast.
Yeah, I'm gonna claim that title.
Yes, please do. Really, you're a wealth of knowledge and I so appreciate your time and for being here today. Thank you.
Oh, thanks so much, Claudia. I appreciate it.
What you put on your body is equally as important as what you put in it. Unfortunately, many personal care products have ingredients that are known endocrine disruptors, and in turn, negatively impact your hormones and overall health. I recommend assessing the products that you use the most and researching the ingredients and the potential harm that they may cause. As you run out of products, consider making some safer swaps. One brand that I love and I've been using for years is Primarily Pure. They use thoughtfully sourced ingredients grown with integrity that are regenerative, organic, and wild-crafted whenever possible. No chemicals, fragrances, or fillers needed. They provide research-backed, results-driven products without compromising your health or greenwashing tactics. Made with the earth in mind, they use recyclable glass and eco-friendly aluminum packaging. Head to primarlypure.com and use code HealthCoachClaudia10 to save 10% at checkout. The information provided is for educational and informational purposes only. I am not, nor do I act as a doctor or any other medical professional. I am not providing healthcare, medical services, or attempting to diagnose, treat, prevent, or cure any physical, mental, or emotional disease or condition. The information shared is not intended to be a substitute for the professional medical advice provided by your own medical or mental health provider.